will be the effect of this on family members? As we mentioned, it's very distressing for the family members when the patients do not act themselves, or if they start having hallucinations or delusions. So it's really difficult for them to take their loved one like that. However, telling them that this is not madness, as we earlier said, as a first principle of non-pharmacological management of delirium, and telling them that we correcting the correctable if we can. So find out the cause, correct the cause. That will help, and of course, being there, lending a listening ear to the family members goes a long way. That how they are feeling, what they think the patient was, and now how has the and understanding the baseline status of the patient is again very important, and family members can help us in that. So yes, I think it does have a deep impact when the patients become delirious on family members, and we need to take care of them. We need to tell them that this happens, when patients are nearing end of life, and we are trying to correct all the correctable causes for it. Dr. Umesh says that the family counseling also important. Yes, I agree, Dr. Umesh. It's purely a clinical diagnosis on the basis of history, examination, investigations. Thank you, Dr. Urmila. Yeah. Dr. Mrinal, you want to say something?
I think it was accidentally unmuted. Any other questions regarding delirium, its management, or anything that we have not touched upon? Please feel free to ask.
Or any other experience that you would like to share?
Parul is asking, is in this case, is there anything that could have been done to prevent delirium?
I feel, maybe letting family to be inside a little more than less often could have helped. The ICU nurses, they can help in orientation protocol with the patient. That helps. And maybe the patient has had some electrolyte disturbances while he was NPO. So taking care of those electrolyte disturbances, I think, could have helped. And yeah, being more empathetic by the ICU team could have helped.
Is there any specific timeline to call it as delirium or to rule out?
Sometimes.
Dr. Roshan is asking that question.
Yes. Is there any specific timeline to call it as delirium or to rule it out? No, I don't think. It is just a change from the baseline, it's an acute change from the baseline. I don't think, not in any of the criteria that I read about exact timeline, like is it 1 day or 2 day or hours. Are you aware of it, Dr. Shri?
No, it's generally an acute change that we notice, and I think that answers the next question also, Dr. Sangeeta, how to differentiate between delirium and senile dementia. Dementia will be slow onset, chronic onset, and the delirium will be an acute onset. A delirium just starts all of a sudden. They might tell you patient was all right till now she started talking in the sleep. And to Dr. Parul's question on the prevention part of it, yes, as Megha mentioned, there are certain things like orientation and time, familiar faces. Many things can be done, but many things which are not avoidable, like some things like ICU admission may not be avoidable all the time. And identifying, if in palliative care setting, identifying whether they have hypoactive delirium also plays a major role. Sometimes we think that the patient is depressed, that's why they are not talking. So if you they say hypoactive patients with hypoactive delirium are more likely to get terminal agitation because it goes unidentified. The other part hyperactive we identify much more easier because they are too noisy or creating a lot of confusions. It's very important to pick up on the hypoactive delirium and start treatment early. And as Dr. Umesh, I think, was mentioning about the caregiver training, very, very important, because as I said in the beginning during intro, caregivers go through the most of the distress because they have to, they see a whole different person one fine day. So we usually come across people using abusive words, which they might not have used in their entire life, and then they start beating up their partners or start abusing the healthcare workers. And the wife usually tells that he had never used these kind of words in his lifetime and we've never seen this. And then obviously removing all the clothes and then walking around naked, so all this will affect their dignity. And the caregivers are very, very distressed seeing this. When someone comes seeing their loved one in this, they may not encourage visitors because this is how they are going to be presented. So that's a very distressing situation. And if you have an elderly person and the wife is also elderly, going through all this, like she herself will be dealing with a lot and seeing this, and how much ever you counsel, they have a tendency to keep correcting the person. No, no, it's not night. No, you had idli in the morning. Why, how did you forget? I remember I fed you. So they take it very personally. See, this guy is lying. I've fed everything or I've done everything. So the lot of interpersonal issues happens at that time. That's what we have seen. When the caregivers start crying, now see how much I have looked after him, but then now he's abusing me a lot. So caregiver needs a lot of support, and sometimes patients after some time they say, I knew that something has happened and I did something wrong. Some people actually recollect many incidents that happen. So all this will be very traumatic for the patient and the family. So it's very important to, and unfortunately, all the reviews says that this drug is not, nothing is conclusive in terms of medical management. You can't say this is the best drug or you cannot use this, you should use that. Every evidence in terms of medications are inconclusive, but general guideline is to start with an antipsychotic, not completely depending on benzodiazepines. But I think, as Dr. Andrew was telling, benzodiazepines works well many a times. So it's all about starting with an antipsychotic, then adding a benzodiazepine will be the better way to go about it, although the guidelines are not really clear about it. Dr. Kalindi is asking how to manage delirious patients at home, like the ones with progressive brain tumors or brain metastasis.
Hmm. So I think in those patients, medical management would be important. Identifying if it's hyperactive or hypoactive, especially if it is hyperactive. In those patients, it's very important to prescribe IV or oral antipsychotic agents. And they are, or maybe as Dr. Sri just mentioned, addition of some benzodiazepines may also help. So yes, I think that there it will be important to have medical management drugs. Yeah.
Yes, Dr. Prakar is mentioning that in ICU settings, midazolam infusions has been shown to increase delirium. I totally agree, Dr. Prakar. We just don't recommend benzodiazepines as the first line. Suddenly, it just aggravates. But it is the most commonly used drug, I think, in many of the settings. People start with benzodiazepines and thinking that the patient will sleep. Uh, but many a times it exaggerates delirium. But with baseline antipsychotic, midazolam infusions work like wonders. So we give haloperidol infusion or intermittent subcutaneous injections. If terminal delirium, it's usually haloperidol infusion along with midazolam infusion. That combination works better than giving benzodiazepines alone. And in home-based setting, sometimes our most of our patients die at home, and many of them have delirium. So we try to educate the caregivers to give subcutaneous injections at home of midazolam if they are capable enough. We try to teach them. We put the subcutaneous line and give the loaded syringes and tell them to give whenever the patient or whatever the haloperidol that we are prescribing. Not for everyone, but for many patients that has worked, giving the subcutaneous injections and training the family members to give the injection at home. Any questions that I missed from the chat?
No, I think we covered everything.
Yeah, I think Dr. Urmila has mentioned delirium may complicate the underlying dementia. Very true. And sometimes the medications that we give for delirium can cause more rigidity and other issues for some patients. Dr. Parul is asking the role of quetiapine.
Patient transdermal lorazepam can be around patch. Transdermal patch of lorazepam. I'm not sure.
I have not used Dr. Urmila. I have not heard also. We use sublingual at home. Sublingual tablets are available.
Yes,
That is commonly used in a home care setting. Even if the patient is end of life care, we tell the patient the caregivers to put it under the tongue, or midazolam or loaded midazolam syringes we do give for subcutaneous injections at home. Midazolam nasal sprays are available, but the dosage is meant for pediatric use, so you will get 0.5 dosages per spray. So you may have to use more sprays.
And the action is also very short, for midazolam. So yeah.
Yeah, I have not used. I have not heard also about lorazepam patches.
Me too.
That would be wonderful if they have lorazepam patches, because it's easier to give in a home care setting.
But again, with patches, I don't know, because they are usually more. The duration of action is more prolonged, so how long to prescribe, and because mostly doses we need to increase or decrease in between. The doses, required doses may not be constant, so use of patches, I'm not sure even if they're available, how much we'll be able to use them. That's one thing.
Role of quetiapine, would you like to comment, Megha, in delirium?
Yeah, so quetiapine is a great oral antipsychotic, just that it's not available IV. If the patient is able to take orally, we can start the patient on quetiapine. Many patients, in fact, it is one of the safe ones. We use it regularly. However, again, I think in this also, both with haloperidol and quetiapine, ideally we should have a baseline ECG, see the QT intervals. They are both known to prolong QT intervals. So just that. Otherwise, quetiapine is a good medication. We can use it.
We also use quetiapine, especially when there are a lot of sleep disturbance along with delirium. We start with a smaller dose, because sometimes people, even with smaller dose, they sleep.
They sleep a lot. Yes.
So, and the advantage is that you can go a little higher with quetiapine. Psychiatrists go much higher with quetiapine, although we don't go that higher. But we do use that a lot, especially when there is a associated sleep problem also at night and day they are not sleeping at all. Then quetiapine we do use. There are no more questions in the chat. We finished much early today. Usually we finish by 4:30. Thank you so much, Dr. Megha, for answering all the questions and sharing your presentation with all of us. Thank you so much, participants, also for bringing up the questions, and Dr. Urmila for the case presentation, so that we could have some discussion and learning from that. Thank you so much, everyone, once again, and see you for another interesting topic the next day. Thank you.
Thank you so much, Sri. Thanks. Bye, everyone.